Hello again, welcome to the part 2 video on osteoarthritis, where I shall be discussing the physiotherapy approach to osteoarthritis. Whereas in my first video, that is the part 1 video, I had introduced you all to osteoarthritis, its prevalence, pathophysiology and pharmacological management. Now, before beginning the actual physiotherapy management, let me put forward the aims of physiotherapy management or physiotherapy treatment, which will be slightly different from the pharmacological treatment, and the approach to would vary. Now, first and foremost aim of physiotherapy treatment should be patient awareness or patient education. And then the aim should be to reduce pain and joint stiffness, then to reduce the quantum load on the joints, then to improve joint range of motion, and then to improve neuromuscular control, strength of the muscle and endurance. And finally, the aim should be to improve gait and physical conditioning. Now let's discuss in detail the treatment plans to achieve these goals. First of all, the patient should be explained about the disease and his specific condition as to what has happened at his joints and how he can improve. Now, don't unnecessarily frighten the patient by telling him how worse his condition is, because it won't help you nor the patient, but instead educate the patients on do's and don'ts. For example, a patient with osteoarthritis has to avoid many things such as kneeling down, squatting on the ground, using Inam chairs, unsupported climbing of stairs, jogging and long walks, carrying heavy weights, unnecessary bending, standing and walking, using Indian style toilets. All these things should be avoided in the best interest of the patient's health and recovery, and the patient should know about this. So educate the patient regarding all these things. Now moving on, for pain relief, various modalities can be used such as superficial heat delivered through moist heat packs, dry heat packs, infrared lamps or paraffin wax. Now these modalities are used to produce localized analgesia and increase local circulation in the area where it is applied. You have to remember that these superficial heating systems penetrate only a few millimeters and do not enter the depth of the synovial cavity of the joint. So, deep heat modalities such as shortwave diathermy can be used for deeper penetration whenever deeper penetration is required. Now, this deeper penetration not only will provide analgesic effect but also affects the viscoelastic properties of the collagen and increases the plastic stretch of the ligaments. Now, in acute cases of osteoarthritis, cryotherapy, that is use of cold packs or ice massage, also can be prescribed. It will increase the circulation and will provide analgesia by working on the principle of Hunting reaction, where the blood vessels constrict initially and later upon sustained icing, they dilate more than their normal size, thereby increasing the blood supply. Now, another modality, that is TENS, also can be used for pain relief, which acts on the principle of blocking the pain pathway. Further, patients should be encouraged to perform non-weight bearing range of motion exercises to the extent possible. However, in acute stages, joint motion should be kept to minimum because repetitive joint movements will aggravate the symptoms of inflammation and it will delay recovery. However, gentle joint play movements or joint play such as Maitland grade 1 and grade 2 joint mobilization techniques can be used, where small and large amplitude rhythmic oscillations can be performed at the beginning of the joint play, not reaching the tissue resistance. Furthermore, for pain relief, grade 1 small amplitude distraction of the joint may be performed along with mobilization techniques, or it may be performed separately where no stress is placed on the capsule. It will help in equalizing the cohesive forces, muscle tension and atmospheric pressure that is acting on the joint. Now, apart from pain relief, these manual therapy techniques will bring about synovial fluid movement inside the joint, which will in turn bring nutrients to the avascular cartilage of the joint and the intra-articular cartilage of the menisci. Now, it also will maintain the tensile strength and extensibility of the particular tissues and will negate the effects of immobilization such as fibrofatty proliferation, which causes intra-articular adhesions and biomechanical changes in the soft tissues surrounding the joint, eventually leading to contractures and ligamentous weakening. Now, coming to the joint stability. Now it can be improved by using splinting techniques and use of orthotics, which not only will give stability but also will negate the forces acting on the joint to at least to some extent. But these techniques should be used in a very unstable joint and only in the initial stages of recovery, because prolonged splinting will again lead to fibrofatty proliferation. Now, the most important part of the physical therapy approach to improve muscle strength, endurance and function is via resistance training. Before I tell you what kind of resistance training is needed in what stages of osteoarthritis, let me put forward the general benefits of resistance training. First of all, it is evidently helpful in achieving greater bone mineral density and less bone demineralization. It has a well documented positive impact on on tissue remodeling by improvement in capacity to repair and heal. Now, resistance and endurance training also causes hypertrophy of the muscle and increases the motor unit recruitment and its firing. And continued resistance exercises will increase the storage of adenosine triphosphate also. Anyway, coming back to what kind of resistance exercise can be used in case of osteoarthritis, initially it's better to start with isometric exercises to improve muscle tone, static endurance and overall prepare the joints for vigorous activity. Now, according to recent research and documentation, isometric exercises are more effective when they are performed at 70% of maximal voluntary contraction, held for around 6 to 10 seconds and repeated 5 to 10 times daily. For example, while performing quadriceps isometric exercise, the patient has to be instructed to push his knee against the resistance, and the resistance is placed behind his knee, applying a force of approximately 70% of his total strength to push his knee. He should apply that much of force. Now, in hip and knee, this kind of isometric contractions will increase intra-articular pressure that will lead to nourishment of the joint by synovial fluid movement. Now, next type of resistance training that can be performed via dynamic exercise, and they can be both concentric or eccentric. Now, these dynamic exercises can be performed using free weights, resistance bands, etc. But these should be performed within the pain-free range to avoid further damage. Also, the patient should learn to perform the dynamic exercises rhythmically with well-controlled movements in the outer range. In osteoarthritis of knee, after extensive review and review of literature and experimentation, I follow around 16 weeks of progressive muscular training, and it's given me good results. Now, finally, I will conclude this lecture by pointing out that specific deviations from the normal gait cycle are also evident in many forms of osteoarthritis. So the clinician or the physical therapy specialist should look out for antalgic gait pattern and address the underlying joints and muscles that contribute to abnormal gait. Okay, so I hope I was clear in putting forward the management of OA, and I hope you benefit from this lecture. Do let me know in the comment sections any questions or anything you want to talk about. Okay, thank you. Take care.